All right, welcome to Module 10, Schizophrenia. So, schizophrenia is relatively rare. It affects about 1% of adults. It is characterized by psychosis, um, so altered cognition, perception, reality testing, so they're just not in tune with what reality is. So 75% actually develop over time, and the set of onset is between 15 to 25 years of age. Um, Onset during childhood or after 25 is more rare, but not impossible. Famous people with schizophrenia include Van Gogh. So we have a theme running through today. It's a lot of art by Vincent van Gogh. So DSM-5, that's how they decide if you have schizophrenia or not. These are the criteria that they use. You have to have 2 or more of these symptoms for a significant portion of time within the period of a month. Okay, so delusions. So remember, important to differentiate between delusions and hallucinations. So remember, delusions are thoughts that are not correct. Hallucinations are things that you experience with your senses: see, hear, taste, smell. Um, Also, disorganized speech. Um, Catatonia, so just like completely just catatonic, so not moving, not talking, kind of staring off into space. Negative symptoms, so we're going to go through what negative symptoms are, but it's an absence of things that you would expect to be there. And then some kind of functional impairment, so you can't live your life because it's impairing. And uh, or you can have continuous disturbance for at least 6 months. So we're going to talk about our friend Eric M. for our case study. So he's an 18-year-old. He's always been a good student. Now, however, his second semester of college, he begins for the first time in his life to have trouble with concentration. When his family doesn't hear from Eric, they contact the school, only to discover that his roommate says Eric is talking weird. Asked what he means, the roommate says, well, he says stuff that doesn't connect, doesn't make any sense. I asked him if he was high or something, he said no, and I believed him. On further investigation, Eric's professors say he's been missing class after starting out so well. So you've got this guy who's a good student, in touch with his family, kind of on top of his game, and then he starts acting out of character. Okay, and he is in that range of onset. Okay. So Eric's roommate says his speech doesn't connect. It doesn't make any sense. He sort of gets derailed. Which of the following symptoms is Eric displaying? What do you think? We'll talk about avolition here in a little bit, but delusional. So delusions are ideas or thoughts that are not true, right? That doesn't seem to fit with that description. Disorganized speech, though, that sort of makes sense, right? So the answer is C. Comorbidities, so things that you would find with it. Substance abuse disorders, so things like nicotine dependence, alcohol abuse, anxiety, depression, or suicide. Some kind of physical ailments. Polydipsia, so drinking more than you should. So this impulsion to drink more than you should. So etiology, lots of different factors kind of contribute to it. So there's biological factors like genetics. There are some theories about maybe dopamine or some kind of other neurotransmitters that are involved. There could be brain structure abnormalities, but there is some component of having some kind of psychological or environmental factors. So just stressors. They can even be before birth, psychological, environmental, prognostic considerations. So environment can make somebody more predisposed. Eric's parents arrive on campus and he agrees to meet with them and a campus counselor. He appears anxious. He expresses sorrow that his grades are suffering, acknowledging that his concentration just isn't there. He says that he feels something weird is happening to me and describes frequent distressing thoughts. He admits to feeling suspicious of everyone he passes. Eric's parents and the counselor both notice what the roommate had described about Eric's speech. Actually had a friend in college who developed schizophrenia while I knew him. He went from being a really outgoing guy involved in lots of different organizations. He was a soccer player, um, super generous, super nice, and very outgoing, and then became super suspicious, stopped going to class, eventually had to move home with his parents. I think he was 20 when all of this happened. So it was very sad because he was a really good friend of mine. But yeah. So phases of schizophrenia. Prodromal, so that's when it starts and you have these mild changes that are happening. Acute is when it starts getting worse. Stabilization is the symptoms start kind of going away, moving back towards whatever your baseline function was before all this started. And then you have your maintenance. So whatever your new baseline is, trying to find your new normal, that's the maintenance phase. So Eric agrees to see a psychiatrist, and an initial assessment and history indicate that he has only been experiencing some mild changes in his thinking and mood for about a month. So probably prodromal, right? Ever since returning from the winter holiday. The examiner confirms that his speech is sometimes disorganized and his ability to concentrate and study is diminished from his previous long standing as a strong student. So our friend Eric is not doing too bad quite yet. Oh, I just answered the question. Whatever, we'll do it again. Given the evidence we have so far, if Eric has schizophrenia, which is suspected, which phase is he most likely experiencing? Prodromal, right? So these are those mild changes in thinking, reality testing, mood. It doesn't really meet the criteria, the DSM-5 criteria for schizophrenia yet. These symptoms can appear a month or more than a year before the first full-blown episode of illness. During this phase, speech and thought can be odd or eccentric. Anxiety, obsessive thoughts, compulsive behaviors might be present. Then you have this deterioration in concentration, problems with school or job, social functioning gets impaired. Um, all of these things are accompanied by these distressing thoughts, being suspicious, trouble with memory, some disorganization in speech or behavior. The patient may feel that they are not right and that something strange is happening. Wouldn't that be so scary? Okay. So during that prodromal phase, you want to identify positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. So this is something that you need to know. So pay attention to all these different types of symptoms because you're going to be tested on it. So reality testing. So delusions. So these are those things that you believe are real, these ideas that you believe are real, but they are not true. Then you also have alterations in speech, and then they have very concrete things. They can't think in the abstract. Okay, so these are adding things that you wouldn't expect there. That's a positive symptom. So let's talk more about what these alterations in speech are. So, associative looseness. So, word salad is an example of associative looseness. It's just a jumble of words that just doesn't make any sense. Clang association is where you they sound alike. Okay. Neologisms, they make up their own words. Only the patient knows what they mean. Echologlia, so like echo, they repeat what you say. Circumstantiality is unnecessary, tedious details. Eventually, they'll get to the point, though. Tangentiality, like a tangent. they get off topic, or go off on tangents, and they never get to the point. Cognitive retardation, so slow thinking, delays in responding to questions, can't finish their thoughts. Pressured speech is like they can't get the words out fast enough. Um, they won't let you comment either because they just have to get all these words out. Flight of ideas, moving rapidly from one thought to the next. It's really difficult to follow the conversation because they're just jumping all around. And then symbolic speech, using symbols instead of direct communication. So um, the patient might report, demons are sticking needles in me. What he actually means is that he's experiencing some sharp pain, but he instead talks about the demons and their needles. Okay, disorders in thought. So thought blocking is a reduction of thought. So you can have hallucinations that can interrupt whatever thought processes you were trying to have. Okay. Thought insertion is this belief that someone else has inserted thoughts into their brain. Thought deletion, the belief that the thoughts have been taken or are missing. Magical thinking, so believing that thoughts or actions can affect others' consequences. And then paranoia. So an irrational fear, anywhere from mild, so you're wary or just guarded, to profound. So believing irrationally that another person intends to kill you. Okay. And Van Gogh famously cut off his own ear. So maybe he was having distortions of thought. Pretty scary, though. If you can imagine that any of these things are true, that would be quite terrifying. All right, back to our case study. During an assessment, Eric has trouble staying on topic, zipping rapidly from one thought to the next, making it hard to follow what he's trying to say. Which speech disturbance is he exhibiting? Pressured speech, circumstantiality, flight of ideas, or tangentiality? That's a really difficult word to say. So the answer is C, flight of ideas. So it's this rapid jumping from one topic to the next. Remember pressured speech is this, you can't get the words out fast enough and you won't let anybody get a word in edgewise because you've got to get all these things out. Circumstantiality is unnecessary details, but eventually they get to the point. And then tangentiality is they wander off topic, they never find it. They just are constantly going on one tangent after another. All right, alterations in perception. So depersonalization is this feeling of being unreal, that you've lost your identity, that your body parts don't belong to you, or your body is drastically just different. Derealization is the feeling that the environment has changed. Hallucinations, so remember we mentioned those, it has to do with perceptions of sensory things. So auditory visual, so auditory hearing, visual eyes, olfactory is smell, gustatory, whatever, taste, tactile is feel, and then command. A command hallucination is really problematic because it's this hallucination that directs the person to take an action. Okay. Uh, walk out in traffic would be a command hallucination. And then illusions. So misperceptions are misinterpretations of actual real events. So all of these definition things are going to be things that you're responsible for knowing. Okay. So make sure you spend some time knowing what they are. Alterations in behavior. So these are all examples of alterations in behavior. Please look them up and understand what they are. So catatonia, we already talked about it, just kind of staring off into space. Motor retardation, so moving really slow, versus motor agitation, where they're really ramped up. Yeah. So make sure to look up all of those things. All right, now we're going to talk about negative symptoms. So this is the absence of what you would naturally assume somebody would have. So anhedonia. Anhedonia is this ability, like reduced ability or just complete inability to experience pleasure in your life. Avolition is this loss of motivation. You can't reach goals. Asociality is that you just don't get any comfort, don't have any desire for social interaction. Affective blunting is this reduced or constricted affect. Apathy is you just don't have any interest or attention to any activities or beliefs that would otherwise be important to you. Elogia is the reduction in speech, sometimes called poverty of speech. So Eric becomes anxious and says, "There are worms under my skin eating the hair follicles." How would you classify this assessment finding? Is it a positive symptom, a negative symptom, a cognitive symptom, or a depressive symptom? So we can rule out depressive symptom, right? So a positive symptom is something added that you would not expect to be there. A negative symptom is something that you would expect to be there that's not. So this is kind of an adding to, right? So he has this perception um, of worms under his skin eating hair follicles. So a positive symptoms includes things like hallucinations, okay? And so uh, this would be a tactile hallucination, right? Potentially. So delusions, paranoia, disorganized, bizarre thoughts, behaviors, or speech, these are all positive symptoms. And remember, negative symptoms are all the things that start with A. Cognitive symptoms are impairment in memory, attention, thinking, judgment, problem solving. Okay. So the answer is A. Okay, so when you do your assessment, you want to assess for any medical problems, because some mimic the psychosis, so depending on what you have going on, right? So if like your sodium level is really jacked up, it can make you altered. Alcohol or drug use. You want to do a mental status examination, which you will do in your sim this week. Cognitive assessment. Assess for any hallucinations or delusions. You want to assess for suicide risk because these guys are at high risk for harming themselves. As you can imagine, if you are, paranoid or, delusional, it would be pretty terrifying. So you can understand why they might be at high risk for that. Their ability to say that they're going to be safe or take care of themselves. What medications are they on? How are they doing in their life? Are their symptoms affecting their ability to function? And then what is your family? What the family know? How can they support you? Where are we at with all that? So the psychiatric nurse conducting Eric's assessment believes that he is also suffering from command hallucinations. What kind of questions could help us discover this? So what do you think? So are you hearing any voices, right? What are the voices saying? Do you recognize the voices? Do you believe the voices are real? Do you plan to follow up on whatever the voices suggest? So the voices are never happy, by the way. It seems like they're always saying unkind or unhelpful things. So, like, for example, the voices are telling me to run into traffic, not friendly voices. So that would definitely be a safety issue, right? So we would need to figure that out. Nursing diagnoses. So acutely, patient safety. So that would be a primary concern, right? Making sure they're medically stable. Phase two, helping make sure that your patient understands their illness, what treatment is involved, the importance of being compliant with medications, how to cope with symptoms, and then the maintenance phase, making sure that we don't lose any ground. How can we prevent relapse? And then finding ways for them to get back to life, right? And try to get back to some semblance of normal. So after an acute admission, discharge is being planned for Eric. What are some things that need to be considered? So where is he planning to go, right? What are his living arrangements going to be? Does he have any resources or social supports? How is his family relationship? And what are his coping skills like, right? And then connecting family with resources, right? Like actually getting them hooked up, not just referring them to different resources to help them understand what they need to do to help support him, right? Social, financial, um, and other resources that can help them be the greatest support for Eric. All right, so we want to, for the implementation, make sure that we do an evaluation, that we treat them with medications, that we start doing this education and support, make sure that we are supervising them for their safety. Um, what kind of milieu would we want, right? Calm, no like pictures that could be construed as like, somebody watching you or something like that. Um, no Salvador Dali. Maybe that would be a little freaky. Eyes and nose. And then if they are aggressive, finding ways to work through that, assess for any risk factors of that, making sure that there aren't things in the environment that can be used to harm themselves or other people. Medications, you go over this in your pharmacology class. Um, there's first, second, and third generation. There are injectable antipsychotics. They can have dangerous side effects. Okay, um, there can be toxicity, neuroleptic malignant syndrome, agranulocytosis, prolongation of the QT interval, which puts them at risk for lethal arrhythmias, liver impairment. So need to make sure that medically that they're doing okay while they're taking these different medications. So would need to do some blood work to monitor for all that. Loose associations in a person with schizophrenia indicate, what do you think? So loosely tying one thing to another thing. So the answer is D, poorly organized thinking. All right. Which assessment finding represents a negative symptom of schizophrenia? So remember, these are all of the things that you expect to be there that are not there. And conveniently, they all start with A. So the answer is A, apathy. So remember, your negative symptoms are uh, like avolition, your affect is blunted, those sorts of things. Delusions, hallucinations, and motor tics would all be positive symptoms of schizophrenia, not negative. And that is Vincent van Gogh, self-portrait. All right, so we are going to meet on Thursday to go over the case study, case study 146. We're also going to do that bipolar case study at that time and help give you a little bit of context. So please come Thursday at 7 p.m. and we will knock that out. And I hope to see you then.